There we go. This webinar is being recorded and will be posted here. Only panelists and the host can share their audio and video. Please enter any questions and comments in the chat and Q&A and be respectful and curious. Okay. So I like to start off by just saying thank you to all our wonderful participants who agreed to be interviewed for this work. We're going to be presenting about results of qualitative interviews we did with 27 Syringe Services Program participants. Really just wonderful how much people were able to be like open with us and what they shared. And then thank you so much to the participating Syringe Services programs for being partners in this work. We're really only able to just show up and do interviews because we're really piggybacking on the relationship that participants have with those programs. Like Teresa and I were able to just pop on over to Mason County or to Vancouver and just be there because participants really trust these programs and therefore trust us as invited guests there. And then thank you to the Washington State Healthcare Authority for funding this work. I also want to just say they did not have did not provide any editorial advice on content, but they did fund this project. So thank you for continuing to fund our work. So for today, we're going to talk about how people use harm reduction programs, how people use treatment programs, if these ever overlap, what do people think about using both kinds of support at the same time? So we looked at sort of the literature and saw things about um, those domains being really separate, but we're really talking about people who are trying to engage in lots of different services. So we wanted to better map what that looked like. So this is part of connected to a larger body of work that we do that includes the biannual, as in every other year, Syringe Services Program Survey, which is happening again this fall. The biannual qualitative interviews we do, including a past one that we did around fentanyl and another one around meth. And then the Perch survey that was done by Saul Petersky about perceptions of drug use and permanent supportive housing. This is just a little sampler of some of our participant summaries from past reports. Just wanted to anchor that this is really ongoing work that we've been doing. So just some definitions before we dive in. Who doesn't want to start with definitions? So for the purpose of our project, we defined substance use disorder treatment as any use of detox, inpatient or outpatient, medication for opioid use disorder, or recovery support or 12-step groups. Syringe services programs included education, materials, and services to support safer use of illicit drugs, such as sterile syringes, smoking supplies, supports for health and well-being of people who use drugs, such as HIV and Hep C testing, hygiene supplies, water, and clothing. So just providing those definitions to sort of ground what we're going to talk about. Oops, I have overactive mouse. Um, interviews were conducted last fall in the following sites at Willapa Behavioral Health in Aberdeen, where Teresa and I were rained on all day, on and off. But did get to interview 15 people, and it was a very busy program. It was a van parked next to an opioid treatment program in Aberdeen. And then Mason County Public Health and Human Services, which is the program Christina runs. It's an RV in a parking lot, and we had sunshine there. It was great. And then I conducted interviews at Share in Vancouver, Washington, which is at a van in a downtown area. And all these programs provided safer drug use supplies, and then Share also provides community drug checking services. So although none of these programs provide buprenorphine, they do provide referrals to treatment programs and other services. So eligibility for interviews included being a current SSP participant, being 18 or over, current drug use, which we defined as drug use in the past week, of like stimulants or opioids, not just cannabis, and having participated in drug treatment in the last 2 years. And qualitative interviews were conducted using a semi-structured guide. Interviews were recorded and transcribed, though I can tell you that a lot of the audio was pretty noisy, but we did our best. And analysis was conducted using rapid qualitative methods using Max QDA software. And we're really fortunate to have Teresa to guide us through all of that, because she's definitely our qualitative expert. So who did we talk to? 27 people across, so 15 in Aberdeen, 5 in Shelton, and 7 in Vancouver. It was pretty evenly split between men and women. Mean age was 42 with a range of 20 to 64, so pretty broad spread. About half of people were unhoused, with another 30% with temporary housing. The majority of people that we talked to identified as white, with a pretty big distribution of different races and ethnicities across the remainder. Um, Everyone that we talked to had used meth in the past week, and 41% of people had that as their main drug, with a third identifying fentanyl as their main drug, and another 11% saying fentanyl and meth were both their main drug. I think really important to note, although these are syringe services programs where people are able to access clean syringes, two-thirds of people only smoked. Um, a quarter smoked and injected, and only 11% only injected. So this really reflects a shift that we've seen in how people have been using drugs, something that we saw in our most recent SSP survey 2 years ago. And now I'm going to hand it over to Leif to explain my favorite chart.
Thanks. So this is a timeline of participant syringe service program and treatment access timelines. So each participant was asked to kind of describe their experience when they first used a stimulant or opioid, first tried an SSP, and first tried SUD treatment. And so on the y-axis here, you can see that participants ordered in duration since first drug use. It's largely sequential in age. However, there are kind of some exceptions where there are kind of jumps and inconsistent numbering with age, because people have different timelines for their drug use and service utilization. And then the x-axis is arranged by years since first time that someone used drugs. So 0 is time zero when someone started, and then going to most recent treatment. The data points that you see here are: purple square is first SSP access. The blue circle is first treatment access, and then the green diamond is the most recent treatment that one of the participants, or that a participant accessed. And as you can see, some people engage in harm reduction or treatment services early in their use, and others had kind of substantial gaps when they between when they started using a drug or drugs until they first accessed any of the programs. Next slide, please. So all participants had used SUD treatment in the past 2 years. That was one of the eligibility criterion. But of participants, 19% were currently in SUD treatment at the time of the interviews. 26% previously had been in SUD treatment during the current calendar year in 2024. And 52% had accessed SUD treatment first, whereas 37% had first accessed SSP services. And 11%, kind of the remaining chunk there, had accessed SSP services and SUD treatment in the same calendar year. So that makes a whole mutually exclusive pie there for those last three numbers. Next slide, please. So I wanted to call out a few, or a couple participants' trajectories just to give an example. So participant 10 at the top here in the purple, a 43-year-old reported using drugs at about 15 years old, and also accessed SSP and treatment services close to initiation of drug use, kind of at time 0, and it looks like time about 2. That contrasts participant 15, who is age 42 at the time of the interview, where they started using drugs a little over 20 years ago and accessed treatment about 5 years after initiation, and only recently, even after their most recent treatment, began accessing SSP. So what you can really tell there, just from those examples and just all over, is that participants had a wide variety of harm reduction and treatment access trajectories, as well as durations of substance use that were not necessarily completely correlated with age. All right, next slide, please. So now I'm going to talk a little bit about harm reduction and kind of what we're going to see. So these were kind of the concepts that were communicated by participants of perspectives and experiences related to harm reduction. So the first was access to harm reduction programming and services. Then kind of the unmet needs and improvements discussed by participants. And then I'm going to talk about services benefits and motivations for accessing harm reduction. And I will use kind of harm reduction and SSP somewhat interchangeably in this context. Next slide, please. So first, I'm going to talk about access and kind of, as you saw with the timeline, participants had great variation in the duration of accessing services. However, 20% started accessing their SSP in 2024. Half learned about the SSP from their social network, friends, other associates, and others learned about their SSP from outreach or just happening by the program. And the main kind of access challenge for folks was that transportation is sometimes a problem. Next slide, please. So I wanted to talk a little bit about kind of the barriers and improvements discussed by participants. I will say that by and large, clients were very happy with their SSP services. However, a number of kind of challenges were discussed. So first, there were barriers to service. So hours of service, location of kind of mobile programs moving around that obviously adds some flexibility and allows seeing a wider variety of clients potentially than might otherwise be seen. But transportation was sometimes a challenge. So that there was some planning that sometimes folks discussed being a challenge. Improvements in other needs that were discussed were dental care, needing dental care, relapse prevention, hygiene services, including kind of like showers and laundry. And then also there was an interest in injectable naloxone in addition to kind of the intranasal form that is oftentimes seen. And then smoking supplies, which, as Allison kind of mentioned, many of the folks smoked and used fentanyl and methamphetamine, which are generally smoked. And so that was something that not always was available. And then alternative access and service models were also desired. So mail order, drop off, home delivery, those types of things where clients could otherwise receive services or resources that they were not able to get in person. So now I want to talk a little bit about services, benefits, and motivations. So next slide, please. So there were 4 domains that participants kind of described related to their service kind of utilization. One was drug checking, which is a service that enables participants to bring in small amounts of substances they wish to use and have them tested by technicians to have kind of a better sense of what's in them. It's not perfect, but it does give some empirical detail about what might be in a substance. And one participant said, I think it's cool, I think it's handy, it's nice to know it's in a drug. The next was medical supplies, such as wound care, chronic disease management type items. And one participant said, I'm pretty sure that if it wasn't for this exchange right here doing what they're doing, I would either be dead or I would not have legs because they're what kept me in my medical supplies so I can keep my wounds clean. So this exchange has been really wonderful. The next kind of items were basic needs. So oftentimes that included hygiene supplies, but other things as well that kind of are basic necessities. So another participant said, I like the newer products. I didn't know were here. So yeah, like nicotine patches, toilet paper, the things you didn't expect to be here, like the antibiotic ointment, wound kits, and like the allergy things and the antacids. Doing certain drugs may cause you stomach problems and whatnot, allergies. So a few medical supplies maybe, but also just kind of basic needs items that we all might want on a given day. And then the last item uh, was positive regard. So just kind of a non-stigmatizing and non-judgmental environment and atmosphere where uh, people are treated with positive regard. And another participant said, just that I guess I get some positive interaction with somebody, where people that aren't demeaning or judgmental, it's one of the greatest things about dealing with the people here. And I think that's just really very important and quite touching. All right, next slide, please. So just in summary, from kind of our data on harm reduction, we know that SSPs are playing a vital role in participants' lives, even if sometimes they don't wish that they need the support that they receive. They're very crucial to kind of livelihood and well-being. They provide a lifeline to critical medical, hygiene, and health supplies that are inaccessible elsewhere, and are humanizing, non-judgmental spaces free from stigma present in many other environments. And from that, we can kind of conclude that SSPs are indispensable to participants, their well-being and the well-being of their communities. And the recommended improvements or kind of the unmet needs and improvements that I talked about demonstrate participants' desire for more SSP-like services and supports rather than changes or modifications to the current or existing harm reduction based approaches that are kind of taken by SSPs and other harm reduction type sites. And with that, I'm going to turn it over to Allison.
Great. And because we're fortunate enough to have Christina here, I just want to hand over the mic to her for a minute. If there was anything that you found really resonated from you about this section as someone who runs the SSP or anything that you wanted to highlight or give context to. Sorry to put you on the spot.
Sure. And I was typing a comment to respond to Judith, which I got caught off. I think one of the things that we provide so many different types of supplies, not just supplies for substance use, but a really wide array of hygiene supplies and I guess I would say basic first aid kits. So Judith asked, what's the difference between medical supplies that treat wounds and wound care kits that are included in basic needs? So we give out wet wipes, hand sanitizer wipes, and antiseptic wipes for cleaning wounds, as well as, Band-Aids and antibiotic ointment, cortisone cream, etc. So I think those might be lumped into the basic needs. And then we also provide kind of higher level wound care supplies for people with severe wounds, maybe chronic wounds. Xeriform, which is a really amazing medical supply that can really help heal things, gauzes, and kind of a lot of higher level things. So maybe that's what they're talking about there. I would say the emotional support thing is one of the biggest things that we've heard from our folks. We engage everyone about whether they want referrals to medical dental treatment. If they're interested in that, we'll make phone calls if they're ready for that. Sometimes it's just that conversation. Sometimes that conversation takes a year before they say, hey, I'm ready to go. I do have one participant in particular who has been in abstinence-based recovery. I think August will be her 1 year. And she still comes to the program regularly just for that support. She always says that we're one of the biggest drivers of her recovery. We helped get her into case management. We're all peer-based at our program. And she just finds having us to be, being able to talk and come when she's having a hard day or hard time, getting that affirmation, getting that love, and that kind of, I would also say, would be part of relapse prevention.
Great. Thanks for sharing those insights. Um, oh, and Judith says, thank you. I work on the Save Lives Oregon Harm Reduction Clearinghouse and working on reporting out our categories and listening to your answer. We are splitting wound care and basic needs the same way. Thank you for confirming our process. Great to have you here.
Yeah, and that's
Um,
absolutely correct. I just want to, that is what participants mentioned. Some with chronic wounds really need some of these higher level kind of wound care items and bandages versus like Band-Aids and such that you might have in your household first aid kit.
And there was one participant that I talked to who was interviewing him and he was like, let me show you how much it's helped my wound. He had a leg covered with gauze and he was like, I'm going to use this Sharpie. I'll draw what it used to be like, and here's what it's like now. So like, you don't have to draw on your gauze. He's like, it's fine. I like to draw. So really seeing the impact that the program was having for helping him manage that really serious health issue. So, we did also ask people about their experiences with treatment, motivation or benefits, access or barriers, and recommendations around treatment. And as I discussed earlier, we did define treatment in a particular way. Um, so, people really had a big range of experiences with treatment. Because of the location of many of our interviews, several people had used methadone from an opioid treatment program. Many people had tried buprenorphine, also known as Suboxone, from a healthcare provider and or on the street. Inpatient detox, outpatient, inpatient SUD treatment, 12-step, and we had one person who mentioned having used Vivitrol, which is injectable naltrexone. The only pattern is that most people had tried SUD treatment multiple times over some of them multiple times even within the last year. They had really varying lengths of periods of non-use, and some of them were currently using, um, even if they were currently, so their treatment and their substance use overlapped. And some people reduced but did not stop use during treatment. So it's just to say that often people's experiences of harm reduction and treatment are not discrete and separate. Treatment and motivations, by this we mean like why they went to treatment. Um, Many people talked about wanting to stop, reduce, or better control their drug use. Some people talked about avoiding overdose and death or improving their health. Several people talked about wanting to stop because to regain custody of their children. That's something we hear a lot. Or to avoid jail. They felt like their substance use was putting them at risk of incarceration. And then these two last categories were that either it was required in order to access housing or shelter or required by a court or housing program. Benefits people described were to learn coping skills. People did say that there were supportive staff. Um, People did discuss that medications for opioid use disorder helped provide stability and help get them off that roller coaster, and that it did improve their health and well-being. However, people did describe pretty significant drawbacks to many treatment programs. We heard a lot about really rigid program rules, including if someone started to use again, having their treatment discontinued. Ineffective program staff. Often people felt like the staff were not that knowledgeable about substance use, um, though that varied. Like one person had been in the same program different times, and they're like, the last time I went, my counselor was no good, but I'm back this time and my counselor's amazing. So it really varied even within the same program. A really big drawback is that often programs were difficult to access, either because of cost, insurance, um, intake, transportation issues, bed limits. It was not easy for people to get into treatment programs. Also, if a program was not a good fit, one person said that their program required a lot of writing and that they were not really good at writing, that they were not a strong writer. It wasn't something they could really do. And so a program that required a lot of writing was not a good fit for that person. Also, people identified that involuntary treatment was not effective for them. So requiring treatment when someone didn't want to go wasn't likely to be effective. So a few quotes for motivations. This person says, I'm 20. I have so much time in my life that I don't want to waste out here. I don't know. It's not worth it chasing something that's never going to satisfy you. So I'm just tired of this lifestyle. I'm tired of these people, and I'm either going to end up in the grave or behind bars, and I'm not really trying to go to jail, and I don't want to die. Benefits. I think this one is really nice. I just needed to, well, I mean, I wanted to change my internal dialogue. I had the small voice in my head telling me these things that I thought were, then I went to treatment and everything that I was speaking was confirmed by somebody really smart. So really just needing someone to help reinforce um, some of the positive things. And then drawbacks, this was regarding treatment requirements. They're like, you get a dirty UA, you're getting kicked out. I'm like, shit, it was terrifying. So Seeing that like a positive urine drug screen meant that someone had to stop treatment was a really big issue, and we heard that more than once. So recommendations, one-stop shop would be helpful, easier access like location, telehealth, or more affordable, flexible programs, supportive staff, including people with lived experience, and support after treatment ends. And before I hand it off to Teresa, I just ask Christina if there's anything that sort of resonated or that you hear similarly.
Yeah, I think one thing that brings to mind is a lot of people think that harm reduction and abstinence-based recovery are totally different things, but there really is a spectrum, and people tend to go back and forth regularly through those processes. A lot of times, people will want to stop or reduce one of their substance, but they're not ready to stop another substance. So it's really important to be able to provide services for, everyone, regardless of where they are on that spectrum. Um, and another thing, with people who are on MOED or medications for opioid use disorder, one of the things that's really helpful when people are continuing to come to the program is we can check in on how that's doing. So we can say like, oh, I see you're on Suboxone. How is that working for you? Oh, it's, you're having these challenges. Well, here are these other options. Do you know how to access them? If you want to talk more, we can do that. So I think that's also a good thing to be able to um, continue that conversation and be able to have a place where they know that it's very non-judgmental and that they can really talk about these challenges and issues that they're having, whereas they might feel a little less comfortable talking about with their substance use disorder counselor or treatment staff.
Thanks so much. And I see Carrie has a hand raised. I don't know if that's an accident, but if you have a question, please just, oh, sorry. You can just put it in the chat or Q&A. So handing it off to Teresa to talk about harm reduction and treatment.
Wonderful. Thank you, Allison and Leif and Christina. For this section, we talked to folks about what they thought about using harm reduction and treatment at the same time. And we asked them about information sharing, these next two kinds of questions about information sharing between harm reduction programs, offering more information about treatment, and about treatment programs offering more information about harm reduction. We also asked participants what they thought about accessing treatment at a syringe service program or harm reduction site. So those are sort of the brief summary of the questions that we asked regarding harm reduction and treatment. More than half of our participants indicated that both harm reduction and treatment at the same time would be beneficial. And I think this person, our participant here, sums this kind of both at the same time perspective up nicely. And they say, quote, I think it'd be pretty helpful to use both at the same time, having services to keep myself a cleaner version, going to treatment to learn all the coping skills and whatnot to do with cross addiction and stuff. That would help a lot. Next slide, Allison, thanks. Participants also emphasized that the positive impact of harm reduction, really echoing some of the things Christina and we all have said so far, that having access to harm reduction as a practical support while working to decrease drug use was really important. This first participant shares, quote, I think one enhances the other. This is the name of our report. The treatment, I feel like it was really hard to quit, but with the needle exchange, it's like slowly weaning yourself down and they can work with you on decreasing and stuff like that, end quote. And the second participant echoes this saying, quote, I think it'd be good because, like I said before, it helps people having access to clean rigs and stuff like that, keeps some away from diseases and everything. So if they're still using, it's still a possibility. So that really both having access to both the harm reduction services and that all of the practical supports that come through syringe service programs while engaging in decreasing substance use through treatment programs was super impactful. There's a recognition that using both at the same time could be hard. So it's sort of a yes, and we should keep this in mind that that accessing harm reduction while engaging in treatment support could be kind of challenging and confusing. So this first participant says, and just to note, about 40% of our participants mentioned something about this tension between accessing both at the same time. The first participant says, quote, I don't know, I don't think that mixes. You can still be using it and you either commit to treatment or you actually take the steps to do it, or you're just contemplating it. I mean, that's where that lies. And so I don't think that's a good mix, end quote. Yeah, those challenges that our participants mentioned, going back to harm reduction while you're working to decrease use, included being back in social networks where substance use is, happening, and being reminded of substance use rituals. One participant talked about the physiological reaction she had at seeing a syringe, and that when she was trying to decrease her use, that was really challenging. So just good to keep in mind that there's some complexity here, and that when we're offering support to folks who are trying to decrease their use, we have to be mindful of these complexities. This last quote sums that up. I'm sorry, Allison. This participant says, quote, you have to pick. You got to pick one or the other, end quote. And regarding information sharing, again, there's a real strong endorsement of information sharing across the majority of our participants. About 52% of them said, yes, it would be really helpful. And this quote here, I think, sums that up nicely. This participant says, I think all the information that a person can get, maybe a person might not know, and they come here and they use this program and they see it. Information is power, definitely. And this echoes what Christine was sharing earlier, too, that can be really, really helpful for participants. Yep, go ahead, Allison, thank you. And here again, we have an important additional note that there are a few participants that express concern about sharing information about treatment in harm reduction sites. And so this is just, I think, a good thing for us all to be thinking about. This first participant says, no, you shouldn't be pushing anything on anybody in the context of a syringe service program offering information about treatment. And the second participant says, no, I mean, I guess to me, if somebody wants it and I don't want it pushed on me, especially if people are deep in using because they'll stop coming, I don't want somebody who's constantly, well, are you sure you don't want to talk about this? Do you want to see this? End quote. And this, I think, suggests to us that it could damage the relationship with participants to push treatment at harm reduction sites. So just that, like being able to hold nuance and having an asterisk in our minds that pushing treatment in a harm reduction setting can convey judgment about substance use and harm that really important relationship that Leif talked about. And finally, we asked participants what they thought about offering treatment options like medications for opioid use disorder at syringe service programs. And more than half thought that this could provide benefits like lower barrier access to treatment, more supportive and less judgmental environment, and access to that kind, understanding staff that we've heard a lot about during this webinar. So this first participant says, quote, I would probably be more likely to engage with that treatment at a harm reduction site than going to a treatment facility like I had before. It would be easier to do here. I'm going to say the relationship that we have with people that run the program here and the ease to which, I feel at ease here and I don't feel as judged. I don't know exactly how to express what I'm trying to say, but it's a less clinical setting. And the second quote here from this next participant, quote, that would probably be helpful for a lot of people because some people just don't like to go into offices and talk to people that don't seem like they're very helpful. Some of the people that are provided in treatment settings never used before, some people have. And then so that's an issue among some addicts. But I think it'd be helpful, I don't know, a one-stop shop, end quote. So for this, for us, this underscores what we know in other contexts, that the relationship that syringe service programs have with participants is strong, and access to MOUD could lower that kind of stigma and critical clinical barrier and offer a door to treatment that otherwise is hard to find. And I think just kind of in sum, what what we hear sort of collectively is a yes, um, and a but, right? So kind of taking this all together, general support was really strong for simultaneous use of harm reduction and treatment programs. And the participants remind us that substance use patterns are really challenging to stop, and they're all wrapped up in place and people. So when we think about treatment support in a harm reduction setting, we have to be really mindful of the importance, first and foremost, of the relationship and the unconditional support that harm reduction programs offer. And that in our kind of efforts to provide access to treatment, we don't damage that really important relationship.
So,
Yeah, then I'll
thanks,
hand over
Teresa.
to Allison. Sorry.
Okay. No, you're fine. I just making sure. Christina, were there any things that you thought resonated or that were surprising to you about this or
No, I don't think anything was surprising to me. This is all things that I've heard from different people. I think there is a very real, the reality is people do sometimes get triggered, especially if they are working on either complete abstinence or they're, trying to reduce one and not the other. Um, a lot of times, people will have a lot of used syringes, so they're saying, hey, I'm going to treatment. I have all these used syringes. And that can be a trigger, right? Both from the space, right, as you mentioned, seeing the paraphernalia, going to a place where that they anticipate with using, or running into the people that they are using with. There's always that opportunity that someone might offer and oops. One of the things that we do offer at our program, if somebody is, going into treatment, is or wanting to stop using, is we will offer to pick up all of their used syringes from a different location. So we say, hey, when you want to get rid of it, we can come to your house, we can come meet up, and we'll grab them from you. Also offering them other opportunities to get the other supplies. So we don't do any syringe or substance use supplies at our office, but they can get wound care supplies, they can get hygiene stuff at our office, or we can meet them at another place. Another thing is, when we do help people get into treatment or case management, we always make sure that we are letting them know that, hey, if it doesn't stick, if this isn't something that works, you are always welcome back here. I think a lot of people have that fear of judgment. Either it's an internal judgment or a fear of, this person helped me get into treatment, and if I have a lapse, then I'm not welcome here again. So we always say, you are always welcome as you are today. We're not going to judge you. That's not going to be something. So please always feel safe coming back here if that's something you want. And we do offer referrals. Somebody had mentioned around the whether it's appropriate for SSPs to talk about treatment or to offer treatment services. I think it is very important for SSPs to offer that and to know how to connect people, because we do have a lot of people who do not know how to access stuff. So they want to get stuff, but maybe they've been in an insular world where they don't know how to enter or what the steps are. It can be very complicated. So at our intake, when somebody comes, we ask, all the questions, and we say, do you want referrals for treatment, medical, dental? We ask that every single time to every single person. But we also make sure we're not just saying, do you want treatment, right? We offer all of these other social supports every single time. And when it's the participants' first time with our program, we do say, hey, we're going to offer these things every time. We can, give you as little help or as much help. We can just give you information, or we can actually make phone calls. We have programs that can help hold your hand, walk alongside you. But always saying that like that is not our prerogative. Our goal for this program is not for you to get into treatment or stop using. We simply want to offer that, every time. And our goal is to help you with whatever your goal is. And I think that again underlines the importance of having SSP staff who are either peers or who have lived experience and have engaged in those types of programs. So we can also kind of explain what that looks like and offer that support to as little of a degree or as high of a degree as that person wants. But it's always client centered. It is always based on what that individual wants. And if somebody, during our intake, if people don't ever show interest in treatment or learning about that, we don't push on that, right? So we're never talking more about treatment if that person doesn't show interest in it. It's only when they say, "Oh, yeah, maybe, yeah, I'm interested. What do you have available?" That's when we'll kind of open up the conversation, and we're always basing the type of information based on what their body language says, what their verbal response and feedback is. And if I can tell somebody's feeling a little overwhelmed or like kind of turned off, we'll just stop the conversation around that right there and go on to talking about something else.
Yeah, thanks so much, Christina. I hope it's really helpful for others to have this context. I know it's always nice to have the different framing. So I'm going to start entering your questions into the chat because we are wrapping up with our conclusions. I do see a question already from Jennifer. We had a few limitations. I just want to call out that the majority of participants were unhoused, so it may not be representative of everyone. We didn't explicitly ask about other types of services, such as mental health or medical care or care navigation, though these did come up. It was a convenient sample. We just showed up, and if people wanted to talk to us, we talked to them. And we only talked to people currently at SSPs. We didn't do the inverse and talk to people at treatment programs about their SSP experience. So it really is limited just to people who are currently at SSPs. So, it is biased towards people who are currently engaging in the program. So in summary, what did we learn? People experienced lots of benefits from harm reduction, including safer use supplies, wound care, basic needs, and positive interactions. Treatment benefits were to stop or reduce use, learn coping or other skills, heal their body and mind, or reconnect with family. However, they were seen as sometimes hard to access or stay in. This is a lot of words, but I'll highlight that people really express broad support for cross-pollination of substance use disorder treatment and harm reduction services, including having services co-located or providing education for each in different settings. People really expressed interest in obtaining treatment and other services at the SSP because of lower barrier access. And they endorsed expanding access to low barrier and flexible programs where supportive staff can provide holistic care and offer supplies to meet basic needs. And I think I have a ghost, but it's just really windy today. Um, and other conclusions, although harm reduction and treatment have different approaches, the majority of participants felt these programs could be complementary. So not so much like a one or the other. And that using harm reduction and SUD treatment programs had substantial benefits. And I do just want to call out that people do see so many benefits from harm reduction programs, and they are often funded on a real shoestring. And for example, like Washington is one of the states we haven't spent any of our opioid settlement funds to support syringe services programs. So there's really disproportionate funding for treatment versus harm reduction, although people are definitely accessing both. Um, let's see. So sort of our big conclusion is funding should be directed to fully support harm reduction programs and evidence-based treatment programs and prioritize lower barrier access. Really, people want help when they need help when they need help. We need to make it easier for people to get the help that they desire when it's a good time for them and make it so it's in locations they can easily access. And that participants, clients, patients should be connected with a full range of services they're interested in to improve their health and well-being, which really people, we were just asking about harm reduction and treatment, but people really brought up a broad range of services that they needed. So this is our beautiful resource slide. We have a nice participant handout, which is what my graphic was pulled from. Colleague Erin McGraw put that together. Links to our related CDER work and links to the full report. So if you have questions or comments, you can contact Teresa or me. And please enter any questions into the chat or Q&A. And we actually already have one question in the Q&A. Jennifer Wyatt says this is a great presentation. Curious if you know whether people sought mental health treatment or co-occurring treatment as well. Teresa, do you want to take that one?
think I think you mentioned, Allison, that we didn't specifically ask about mental health kind of supports. We were focused on SUD treatment. So I think we did hear pretty consistently that those kinds of supports, behavioral health supports, were impactful. But it was outside of the scope of this particular study to really be tracking those in a detailed way. I hope that's sufficient.
Yeah, we didn't specifically dive into that in our analysis, but good question. Are there
Yeah,
any
I can
other?
jump in from
Yeah.
the just general
yeah, great.
experience at my program. So our program has been running for 7.5, oh, almost 8 years. I would say that mental health services are one of the least requested referrals that we get. Most people, as far as behavioral health referrals are looking for detox facilities and inpatient treatment. I will say that a lot of our participants both have co-occurring challenges with mental health and SUD. So when they are on the phone with their doing an intake, the at a facility, they would determine whether that person needs a co-occurring or not. I have had more referrals to crisis support, so not necessarily like designated crisis responder level crisis, but people who are feeling like they are in a state of crisis. And so that is one of the places for mental health that we do. And sometimes we'll call our mobile crisis team or work with a program that does intensive case management for people who have mental health as a primary concern and SUD maybe as a secondary concern. We do have we have had some referrals and warm handoffs to a psychiatric ARNP. We have a mobile psychiatric ARNP. We actually did start doing some clinical services 1 day a week with a mobile health team, and part of their team does include a psych ARNP. So she has been called for several of our folks and is able to meet us, while we're doing kind of like a street outreach based program, and has been able to reconnect people on their psych meds and get people in. And oh, I also just want to throw in one of the biggest barriers, one of the things that I'm excited that we've been able to help as far as helping people get into treatment is a lot of people have pet care, and I know child care is another issue, but a lot of people have a hard time. The biggest barrier to going to inpatient is having animals. So this mobile team that I am talking about has a relationship with our Humane Society, and they've been able to find immediate fosters for people who are interested in doing that, and that's been a successful thing too. So I think that really looks. I think that highlights how stopping use or going discontinuing their use or going into getting services. There's so many things. It's not just as simple of like, yes, I want to go. There's so many conditions and so many things that really go into somebody's ability to even start that process. And that is something that I think is really unique and something that could be expanded. Um, but I think also with mental health, a lot of times people might not even quite be ready to address their mental health until
Yeah,
they're stabilized. And a lot of people that we work with are experiencing homelessness and are constantly experiencing trauma. And it's hard to start working on addressing, old trauma when you are currently experiencing day-to-day trauma. But because we are peer-led, and I talk about my mental health challenges and my experience, we've also had people come to me and say, "Hey, Christina, like I was really inspired by what you said and your experience with medications, and that has inspired me to now seek out and stabilize that." So I think also having that conversation and being open and talking about our own things in conversation with that person can be really inspiring. And again, that's one of the reasons I think SSPs or access through SSPs are really important, is they have the opportunity to talk about things on a low stakes level,
Yeah.
or explore, if they're in the contemplative stage, explore what that could be, or explore what their motivations or their drawbacks or challenges could be with people who really are non-judgmental and who are not going to be pushing an agenda to them.
You're getting a lot of
Yeah.
support for this pet care.
Yes. Oh, it's so
Lots of hearts.
it's so so good that you're able to offer it. I just wanted to underscore what you're saying, Christina, about sometimes not being ready to enter into mental health support um, at the beginning of seeking treatment. So, in a study we did in 2021, 2022, we heard often from folks that were engaged in MOUD that they couldn't even think about their mental health, kind of getting mental health support until they were stabilized on medications. And I think that sometimes we think, making mental health support mandatory is the right thing. I could think that's out there in the ether. And I think, the patient-led, patient-centered, that model of really listening to what people need and how they need it is so important. So thank you for emphasizing that.
And I do want to call out, and we have a nice comment from Jennifer earlier in the chat. I really appreciate this framework of drawing from both harm reduction and treatment based on the person's goals. It's very practical and reflects the true nature of working with people. And I think that's what we really heard, is that people didn't see, like, they weren't philosophical about what they were using. They're like, I need harm reduction because I don't want to get HIV or Hep C, or I need, access to safer use supplies. I need treatment because my drug use is not working for me anymore. So people had really practical reasons for using the different domains. And I know that philosophically, those often come from a different place, but we need to create programs that reflect what people say they need and make them easy to get, and not set up artificial barriers for people to get them, and also to fully fund programs that are really effective for people. Like, harm reduction is an evidence-based program. We know it prevents HIV. We know it helps people stay healthier. Um, it's really, we have really strong evidence around that. So to better fund that is really essential, I think. So are there any questions? I just see a lot of positive comments, which I'm not hating, but if people do have any questions, we're here to answer them. And Jennifer says, totally agree, Allison. We need all the approaches together to help people in the ways they want it.
100%.
I had one more thing around the co-occurring issue. Um, at our SSP, to give out syringes, it's 18 and over. Other services are not, but for that it is. But I have done a lot of, overdose prevention work and harm reduction work with younger people. And in Washington State, we just have a real lack of capacity for inpatient services for young people who have co-occurring. So there's only a couple of facilities that will take somebody who has, a mental health diagnosis or a severe mental health diagnosis. And sometimes just getting people into a facility is really, really challenging. And even, we're a rural county. We only have one inpatient men only place in our county. We're going out of, the county across the whole state for folks. And that can just really be a big barrier for people who do need co-occurring services. But that it is limited in what's available, especially for younger people.
Yeah, I remember attending one of your Mason County opioid meetings at the lovely Alderbrook Resort, uh, but hearing a lot and the limitations of treatment options for people 18 and under. And I think we've heard that statewide, that that's a really big gap and a really big challenge, especially for young people who need inpatient, or even for young people who need medications, just because of the stigma around medications, especially for younger people. All right, any questions? I'm seeing lots of agreement. You can disagree with us too. That's also fine. But also happy. We have 2 minutes left if anyone has questions. All right, I'm not seeing any. So, oh, I just see a thank you so much. And thank you for doing the survey and advocating for native interventions. Y'all are rock stars. That's very nice. So appreciate
Thank you, Irene.
that.
And
Maida, yeah.
Maida. Aw,
And Amy, thanks so
aw, and
much.
Maida. Sweet.
It's great. All right. Yeah. True enough. And thanks for joining us so early. Not so early, but like a 9 a.m. webinar. So really appreciate it. And if people do have any questions, just reach out to me or Teresa or Leif, and we're happy to present again if there's another audience you think that this is a good fit for. Because I think for me, I just really appreciate the chance to share the perspectives of the people that we talk to.
100%. Thank you all for coming, and yeah, just echoing Allison, let us know if you have any other questions that you didn't ask during the webinar. You can certainly reach out to us, and we're easy to find, I think, on the interwebs.
Thanks so much.
Okay.
I'm going to stop the recording.